Good morning. Happy Wednesday. Welcome, everyone. We just have our attendees are just jumping into the session now, and I'd like to introduce myself. I'm Cheryl Giesbrecht. I work at Shared Health, and I'm happy to be your moderator this morning. This is our third Wednesday of our RAAM Knowledge Exchange, and we have a really great session today. This is the second session for today, for November 26th. We have a symposium discussion on Indigenous community partnerships, and our topic is strengthening the Manitoba wildfire response. We have a great group here to present today. They're going to present for the majority of the session. If you have any questions during the session or even just shortly after the presentations, you will find a little box in your upper right hand of the screen. It's got a little question mark in it. You can enter your question there, and we're going to take questions and present them to the panelists at the end of the presentations. And so without further ado, I'm going to pass it over to our host, Daniel Decom, and he's going to provide us with the land acknowledgement as well as introduce the session. So take it away, Daniel.
Thank you, Cheryl. It's so good to have all of you here for the RAAM KE Days presentations. We're very honored to have our guests here with us presenting today. I do want to take a moment as we're getting started to acknowledge that health services across Manitoba are provided in facilities located on the original lands of First Nations, Inuit, and on the national homeland of the Red River Métis. Manitoba's health authorities respect that First Nations treaties were made on these territories, acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit, and Métis people in the spirit of reconciliation. And on a personal note, as a descendant of uninvited colonizers, I want to acknowledge that my own life has been filled with benefits that have come from the harms of colonization. And so part of my work in the system is to not only acknowledge the treaties and the land, but to acknowledge my own responsibility, as we all have in reconciliation. So we have three groups presenting with us today, and we're so excited to have all of them with us. I'm going to be passing the microphone back and forth between different groups as we go, and we're very excited to be learning from the experiences of the organizations that have provided critical support during the wildfires. And it's our responsibility as members of health organizations and as citizens here in Manitoba to take these lessons seriously and to move forward with learning and growth. So the first presentation we're going to have this morning is from Southern Chiefs Organization. We're happy to welcome Magnus Musso, Laurie Mainville, and Ashley Daniels. So I have made Magnus, I've made you the presenter. You should be able to share your screen. And I'll ask our presenters.
Oh, while go ahead, Magnus shares his screen, maybe I'll just introduce us, or myself at least, until he can get it figured out.
I can also, sure, that'll work. I can also
whatever
make
you
one
want
of
to do.
the
I
other.
don't know.
Yeah, that works fine. It looks like he's. It looks like you're sharing and you've got your presentation up. And what works best on GoToWebinar is if you hit the little book icon near the bottom. There you go. You got it going. Okay, thanks so much. I'll turn up my mic.
Thank you, Magnus. Thank you, Daniel. And I think it was Cheryl, right? Yeah, good morning. My name is Ashley Daniels. I am from Peguis. So I guess each of us will just introduce ourselves and our role within the Mobile Crisis Response Team with Southern Chiefs Organization. Also, just like to acknowledge the water that comes, the water in Winnipeg comes from Shoal Lake 40. So just a water acknowledgement. Yeah, my name is Ashley Daniels. I'm from Peguis. My role within the mobile crisis response team is a team member. I'm also a psychiatric nurse, and I've been on the team for going on 2 years. And yes, I'll pass it over to Lori.
Sorry, I'm just so used to Teams. Morning, everybody. Thank you for the invite to participate in this panel. I'm originally from Treaty 3, Ontario, lived and worked in Winnipeg since the mid-'80s. I am the wellness coach with the Mobile Crisis Response Team, and I started 2 years ago, September. So thank you. Magnus? Magnus, your mic's not on.
Okay, there we go. Is my mic back on? Hello? Yeah, it's good. Okay, good. Good morning. My name is Magnus Musso from Sandy Bay First Nation. I joined Mobile Crisis Response Team in September with Lori. So yeah, let's get going. Ashley, you ready?
Yep.
Okay.
Okay, so we are 3 of 6 team members within the mobile crisis response team. We have 6 team members, 1 case worker or case manager, 1 intake worker we also have team members that work intake as well. So we have 1 main intake worker and then a team lead and I guess a lead above her that oversees other programs. And MCRT was created, I think it's going on 4 years now, and it was at the request of the 32 chiefs within Southern Manitoba under Southern Chiefs organization. And our primary work is to support those members under Southern Chiefs, the 32 Southern First Nations, and we work collaboratively with knowledge keepers, elders within the communities and other Southern communities, and we try to maintain a culturally appropriate, I guess, way of working with members, whether it be, more traditionally cultural or whatever their faith-based may be. And we work with them where they're at and what their needs are. We also provide, I guess, mental health assessments and clinical wellness. So there is some follow-up after we're done working with those members that might be experiencing some type of crisis or just, needing extra supports. And so I guess our primary focus is crisis response and intervention, and the team also provides support services. Lori, she's a wellness coach within the team, so she will do a few follow-ups, and we're short-term. We're short-term. Anybody can call from any of the Southern First Nations. So yeah, we come from a culturally responsive and trauma-informed lens. All 3 of us have, grew up in our communities and have been able to walk in those 2 worlds, the urban centers and our communities that we come from. And I really think that it makes a difference in the way that we work with the people that we work with. Let's see. We also have one of our team members who speaks Anishinaabe, so that it really comes in. It really helps. It makes a difference in the way that we're able to relate with with the people that we work with. Just gives us a way in to help support them better. So we have many years of experience as a whole, as a team. We have psychiatric nurses, therapists, trauma-informed counselors, mental health specialists, cultural advisory therapists. We also have people who are social workers, who have worked front lines with CFS. There's 3 psychiatric nurses on the team, and others that have also worked in previous roles with a mobile crisis response team. Yeah, so I think we have a wide range of experience along with our own lived experiences. Can you next? So a little bit of the timeline about working with the wildfire evacuees from northern Manitoba. We were called out, or we were deployed, I guess. We were requested to attend the Winnipeg sites beginning May 28th, and that lasted until June 6th. After June 6th, or end of May, we were I think about 4 of us were deployed to Peguis, and then the other team members were deployed to Saging, and that was for about 2 weeks. And then beginning June 4th to approximately August 29th, we were deployed to Brandon, and that was our main site. That's when I guess MKO had asked SEO to kind of take over that portion of the evacuees at that specific site. So that's where our main focus began with the evacuees. From there, MCRT was also deployed to Portage from June 13th to July 4th. And then August 15th to September 15th, we were also deployed to Niagara Falls. On top of all of our wildfire evacuee sites that we attended, we were also being deployed to our 32 Southern First Nations when a crisis would come up, and we would respond to that. Next. So when we were at all of the sites, which were the hosting communities, Saging, Peguis, Winnipeg, Brandon, Portage, Sioux Valley, and Niagara Falls. The communities that we supported were all of these listed: Matthias, Colombe, Marcel Colombe, Cross Lake, Nelson House, Opaskwayak, Chimawawin, Tatasquayak, St. Teresa Point, Garden Hill, Wasagamack, South Indian Lake. And then there was also several community members that were living in Leaf Rapids, Flin Flon, and Snow Lake. They were members of the MKO First Nations, but they were living in those towns. But we were also supporting, non-First Nation community members from those 3 communities, like Leaf Rapids, Flin Flon, and Snow Lake. So yeah, those were the First Nation communities that we worked with, and the other communities that we helped support as well.
Okay. Guess it's my turn. Okay, so as you can imagine, the impacts were greatly adverse, impacting individual, family, and community, and nation as a whole. types of trauma that we identified and observed. And of course, we don't have any like clinical reports or any diagnosis, but things that have been mentioned to us, is the emotional and social impact, health impacts of anxiety, panic attacks, depression, PTSD caused by the evacuation, also pre-existing from past experiences. Talked to elders, talked about residential school and dislocation, talked about impacts of CFS, health, justice, all these things that they were already experiencing in their home communities. And this compounded their lived experience. Fear, anger, dissociation, feelings of loss, unresolved grief and loss. And that also is pre-existing as well. And also another element of it having been evacuated as well. Losing locations of their family members was a big thing. People were worried about their family members, worried about their health, worried if they were getting their assistance, and whether it's financial, mental health and wellness, whether it was connection to systems, and so on. So this was due to the quick efforts of evacuations. Restlessness of children was huge in closed spaces in the hotels. They were only allowed to, they kept their families close. They're really, that's what we observed. And there's very limited recreation activities or social activities, young and old, like the older children. One of the things that I observed, and it's not on this list, is that a lot of youth, when this first rolled out, the evacuation first rolled out, is a lot of youth were staring into space, not even on their devices. I noticed a lot of that in one of the communities that I went to. Concerns of evacuees at evacuation sites. There were evacuees that needed assistance with healthcare concerns, were worried over the healthcare of their family and relatives. Impacts on mental health, social and physical health issues, substance use, poverty, healthcare needs, childhood health conditions, elderly care, justice, probation, etc. This critical incident has increased the vulnerabilities of the community members, which has been traumatic, having been evacuated from their home communities. So all kinds of things were happening. Next slide, please, Magnus.
Yep. It's there.
Okay. Oh, okay. I got it. I'm looking at mine because the font is really tiny on yours. I need new glasses. Okay. So a continuation of trauma from colonization as First Nations people as a whole. We were here listening to stories, we were outside, while they were having smokes, and they talked again things like about residential school, being in day school, and being dislocated in certain areas in their home communities. So we're starting to hear like the historical context of colonization. Continued distrust in government officials at all levels, safety issues. Family members were going missing. There was an element of exploitation. And of course, drugs and alcohol, right? Exploitation is connected to exploitation. And when I talk about, when I say that, sexual exploitation, we've been hearing stories about that. Fear of security personnel that was contracted to watch the hotels and not the people. So there was that cultural, there was that conflict around communication, value systems and so on. So there's fear around that. Easy access to alcohol and drugs, increase in family violence and domestic violence due to the increase in alcohol and drugs, and also just the isolation and then closed spaces as well. That also brought the domestic violence out, and the inability to leave to go visit family and friends. And sometimes the family and friends were in another city or location entirely, or in flux. There was always movement going on. no aftercare for evacuees when they return home. A lot of people are wondering, what happens to us when we go home? When are we going home? So there was no process in terms of what we were hearing. Lack of resources for evacuees and helpers in the communities. This certainly was at the beginning and throughout. No on-site drug and alcohol resources. There were pamphlets that were provided in some of the sites. Not all evacuees read or understand what they were reading. So in terms of support and resources, actually on-site support, that was limited. So thank you.
So positive assets and changes. Community members stepped up to be the voice, especially in Brandon and Portage. We had two ladies from the community that lived in Brandon or Winnipeg, and they came to Brandon to help with the people. Sagging started to develop their own community crisis team, assisted by MCRT members. Community organizations stepped up to assist evacuees. Crocus Plains High School provided home-cooked meals. Manitoba Métis Federation provided home-cooked meals. Some other community members provided meals as well. So many donations from communities. We had some coming in from Rolling River, Kesey, just all around Brandon. Recommendations for future evacuations crisis. RAAM clinic on site, not daily, but to have a schedule. A resource fair, a hub resource center. A private room for medical and mental health services at each hotel. Activities planned for youth, adults, and elders. Identify translators. Improve transportation for evacuees. Improve communication with all organizations involved. Daily multiple activities, like in Niagara Falls, they had 4 or 5 events a day. Improve involvement from child and family services, family enhancement teams, and respite. To have cultural advisors, elders, and knowledge keepers at each hotel room, and to keep a team to work with specialized toddlers and youth activities for those that were missed during this last year.
This is
Yeah,
Daniel,
last
the
one.
host. Last one. Okay.
MCRT best practice: reporting procedures, debriefing, relationship building, promoting hope, belonging, meaning, and purpose, bridging connections with a variety of services and organizations. Acknowledge lessons learned. Thank you.
Thank you so much for presenting. We're, I think that those lessons learned are critical, and we're definitely very appreciative of you sharing them with us, because they were hard-won lessons. I'm going to move us along pretty quickly, and I'm making our next presenter. Hold on a second. I think I've done that wrong. Our next presenter is Ashley DeRosier from MKO. Ashley, you should be able to share your screen now, and I'll let you take it away.
Good morning, everyone. I'm Ashley DeRosier, the Emergency Management Program Manager with MKO. I do not have a presentation that I will be sharing today, but it's more going to be a general overview and just delivered verbally, so thank you. So the presentation focus today is why addiction supports and mental health must be part of emergency pre-planning and response for First Nation communities, highlighting on some of the gaps that we found, and the goal is to ensure no one's well-being is overlooked during disasters. So just a high-level overview. This summer, as we know, the 2025 wildfire season was unprecedented. It was a record-breaking wildfire year where over 21,000 First Nations were evacuated from their homes and displaced for more than 100 days, enduring trauma, family separation, and disrupted healthcare, including stopped counseling, lost access to medications, and sudden withdrawal if supports weren't in place on time. So during the 2025 wildfire season, I actually do want to take the opportunity and thank SEO for their great presentation. Your mobile crisis response team, we want to take the opportunity and commend your great work. The partnerships that we had with your organization during this summer was greatly appreciated, and we look forward to working with you again. And to our sister company there, Kim, good morning, Dr. LaValle. Thank you for the quick response there to set up the MAPS program, where I'm looking forward to hearing your presentation and definitely carrying that conversation forward. So thank you. So MKO was there to support coordination and advocacy during this wildfire season. We worked really closely with the First Nation leadership, the on-the-ground First Nation emergency coordination teams. We also deployed hotel support teams that went to each hotel, pulling staff from different programs to just be there as social supports or be there to meet any needs that were falling through the cracks. Another thing that we did set up was a cultural food and donation program. So throughout the summer, we did have tents set up outside of one of the congregate shelters where elders and First Nations can come access traditional foods. That was a great program, and we're hoping to see that be included in more of the pre-planning and response plans moving forward. I can't thank everybody enough for the mobile crisis response partnerships that did form throughout the summer. There was a huge amount of area that had to be covered, including the city of Winnipeg, Brandon, Portage, all across the south there. So we're really thankful for all the partnerships that did come to fruition to support mobile crisis. So ensuring addiction support. So MKO recognized addiction supports as a gap, and somebody needed to take action. So we're very thankful that Kim stepped in there. During the whole thing, we noticed that there was a huge gap in just mental health and addiction supports all around. It was not something that was included in response plans. It was considered as an afterthought. So once everybody was evacuated, I can't recall exactly, but days after that initial evacuation was declared and folks arrived here to the city of Winnipeg, it was a gap. And we know that that was one of the main concerns at the congregate shelters and at the hotels. And this needs to be something that we encourage all partners and everybody to consider in their pre-planning efforts. Don't think of it as an afterthought. Think of it something as we work towards. It's also important that we recognize the disparities within each of the First Nations. So within the First Nations, there's already limited mental health and addiction supports available to them. If they are getting the care that is needed to support them in recovery or getting through the addiction, those resources are limited. So when they are evacuated, they now come to a very stressful situation where the access, the withdrawal, and the relapse are more likely. With that being said, if we can encourage everybody to incorporate pathways, so if there's folks and First Nations, brothers and sisters in each community that are trying to get through this, trying to get through addictions and recover, we need to be sure that we support that pathway, so that when they come to the city, they do not take the stressful situation and turn to relapse and have to go through withdrawal alone. We should be there to support them and provide that pathway beforehand. And then I can't stress it enough, but the stress and trauma that the First Nations faced during evacuations was extreme. They come to chaos evacuation situations where there's crowded shelters, the family separation, and all the uncertainty. These can exacerbate all the mental health issues and the triggers for new trauma, just recognizing our history. So First Nation evacuees in the hotels and shelters, they showed increased anxiety, depression, and behavioral crisis, especially without familiar support systems. Coming to a large urban center where they don't know where to go. There's no clear roles or responsibilities identified that this is the organization that's going to be here to support you for mental health and addictions. They get here, they don't know who to turn to. They're put in a hotel room with limited to no information on where to go to access some of the information and services. And some of the gaps that we did observe. So like I said, there are no early mental health response. This was absent during the initial surge. So when they get here to the city, there was no dedicated teams that were on site when needed the most. when they get here after a traumatic situation. And we know that it was. A lot of the First Nations had wildfires knocking at their back door, where when they had to leave, they had to get in that plane and get out of there immediately. If we think about the trauma and the stress that imposed on mothers, grandmothers, the children, and when they get into the city, they're put in a lobby of a hotel and said, here you go, let's wait here until we get you a hotel room, with nobody there to support them. We're thankful that the mobile crisis teams and anybody that was available, we got there. We got to those lobbies, we asked how they were doing and if they needed any support. But those are the things we need to consider. We need to think about that day 1, but also day 30. When they first get here, ensuring that there's proper pathways, and once they get into congregate shelters, that we're maintaining those programs and those supports. And then also the delayed harm reduction. We see that MAPS program was beneficial, providing safe alcohol to dependent evacuees to prevent withdrawal. This happened later in the process. I think we need to support this and be sure that those pathways are in place for folks who want to utilize the program, that it's here and predetermined before they arrive to the city. Another thing is shelters. The big thing with shelters, and we saw it happen throughout the summer, there was the large congregate shelters. We've seen spikes in mental health crisis and substance use. And that just happened whether it was in the property or within the facility. So many evacuees struggled being away from home. Some turned to substance to cope or help cope with experiencing panic attacks. We need to be sure that we're supporting this, that when we consider our plans for congregate shelters, this can't be an afterthought. The afterthought that was provided throughout the Manitoba response was after we seen the spike in addictions and mental health. It was like, now what do we do? There was no plan in place. We were thinking on the fly, maybe let's set up another congregate shelter to support folks with mental health and addictions, and that never happened. Unfortunately, there became a system where it was, you go to the congregate shelter, you get a hotel. If you're evicted from the hotel, you go to another hotel. And then if you're evicted, you get to this last hotel. And if you get evicted from there, there was no pathways. And this was thinking on the fly. I'm gonna get kind of passionate about it because I think this is a very important space and an open space to discuss this. But these were just the realities and the findings of the whole situation. So this needs to be something that we're planning for. This can't be something that we're just thinking on the fly, pulling partners together. With all that being said, I do also want to recognize that this wildfire season was unprecedented. This was an extreme wildfire situation, but it is important that we take the gaps, we take the reviews, and we start planning for it. Let's not wait until the next 20 years when this occurs again, or even sooner because of climate change. Let's start planning this and incorporating these into our plans. We have an opportunity out of an extremely unfortunate situation where we've seen partnerships form throughout this summer to talk about this. We're thankful for every partnership, every partner that pulled us into meetings to talk about this. We have a great opportunity to evaluate an extreme situation that showed gaps that would never show on a normal summer. So let's review them. Let's keep our partners encouraged to keep evaluating it and keep planning for the next extreme event. So the key takeaways there are emergencies can create secondary public health emergencies of mental health trauma and uncontrolled addictions, if not proactively addressed. The Manitoba wildfire experience underscored that ignoring these needs leads to human suffering and chaotic response, whereas planning for them can save lives and stabilize evacuees sooner. Another challenge that I do want to highlight is fragmented jurisdiction and limited funding resources to address something like this. The responsibility for providing emergency mental health addiction aid is very unclear. Who takes this responsibility? Is it the federal agencies? Is it provincial health authorities or NGOs like the Canadian Red Cross? But there is no single body that ensures that these services are in place for First Nations during evacuations. So many services that did pop up came up by organizations, partners coming to the table and saying, we're here to help. What can we do? Let's put something in place. Whereas if we plan for it, this can be something that we can also advocate for to ensure that programs such programs that are needed are funded, are adequately equipped, and we remove some of the jurisdictional barriers and develop a clear path. Whose main role and responsibility is it to provide mental health and addiction supports for First Nations during evacuations? Another thing are cultural barriers. So throughout the summer, we've seen great partnerships again with the Spirit team, the Turtle team. These were cultural programs that led with respect, dignity, compassion, and being there to support the First Nations while also valuing the culture. This made a safe partner. This made somebody who they knew they can talk to, they knew they can call. They went into the hotels, they were there, they became a familiar face and a person that they can go to, that they can trust to talk about some of the issues. So I do want to take that opportunity to uplift that those First Nation organizations and partners that were brought in for a short term, again, if we plan for it and incorporate it in sooner, they can be there upon their arrival and when they depart. But in that service also being delayed, we've seen an improvement in morale, in sharing, and in reaching out for support when those other organizations came into the response. Another thing is training for responders and folks who are helping in congregate shelters. We do need to make sure that everybody has some basic training in harm reduction, and then also the burnout and the trauma, that we're working out these schedules where our teams are well supported. This was a long run. This was a long summer. And what we've seen is teams burnt out. Our resources were strapped so thin. So if we can find a better way to work together, find rotations, build each other up and incorporate our plans together, I think we'd be in a better situation. Also trauma-informed training. Not only that, but for the frontline workers to understand First Nations, to have that adequate training when they're working in congregate shelter, know who you're there supporting, know their history, know their hardships, so that when you're there, you don't lead with discrimination or racist remarks. You're there to support the people. I can't say it enough, but the cultural safe approaches were great. Like seeing the cultural food program that was administrated, people went to those programs, people went to get the traditional foods. So if we incorporate more cultural safe supports into our emergency plans, I think folks they'd feel more comfortable, they'd feel recognized and respected and treated with dignity, and having the availability to make the decisions and have what they want there as what they would have back at home. And the Indigenous-led organizations. I am very thankful for all the Indigenous-led organizations that were a part of this response. And we've seen better engagement. We've seen better crisis mitigation, having the First Nation safety officers there in Brandon. We've seen unsafe situations become safer, and the First Nations more open to talk about these things during the event. I'm going to skip down here to my conclusion. So emergencies like wildfires and floods, they are inevitable, but they're stressful and they are very disruptive, but they need to have a plan. They need to have a plan in place for mental health and addictions. We need to be proactive, and we need to integrate these supports into our emergency plans, and also have clear roles and responsibilities of what each partner is doing so that we can better work together. That's it for me. Thank you very much.
Thank you so much, Ashley, and I appreciate your passion and the passion that you're bringing to this. And I think that the lesson you're leaving us with is it's so important. We're only going to learn from this if we let ourselves, right? And being proactive is, that we've seen what this season can be like now. We've seen what the wildfires can do. So we really need to learn those lessons and be proactive next time. Thank you so much.
Thank you.
I am going to, for our final presenter, I'm going to turn things over to Dr. Barry Lavallee and Michael Dubé from KIM, from Kim, and I'm making you the presenters. So if you have slides, you should be able to share them now.
Yeah. Okay. So just, is the mic off? Yeah. Can you see the screen?
We can see and hear you.
Okay, perfect. Thank you. Hi, my name is Barry LaValle. I'm the CEO for Yahweh. And I want to acknowledge SEO and MKO. You guys had the most complex job with little support, I think. And what I've been thinking about is that the next time is for the governments to provide us with enough money and support. You know, 5 people can't take care of all Manitoba and Niagara Falls. You know, those expectations are really, by the system, are really unrealistic. So I want to acknowledge SCO and MKO. You guys had a wicked job because this was a really tough summer. We got called by the minister for homelessness to actually, who said that there was lots of noise in some of the sites, meaning that there were a lot of people really traumatized and really wanting to take care of their trauma by using, you know, alcohol primarily, but other drugs as well, as all you know. So we're going to do a really quick presentation. What I really want to do is I'm going to, Ken Mackenzie is here. He's our senior clinician actually in harm reduction. I want to just emphasize what an intervention looks like and how it changes the mood, the emotions, all those kinds of things of participants in a managed alcohol program. So just, so we were asked to do that. We've been involved with managed alcohol program for about, well, since the pandemic when we started one in Shamattawa. We have active sites in Thompson at the Wildfire Center as well as in Winnipeg here. And we're moving towards looking at a managed alcohol program in First Nations communities and in territories that we work. And for all of you, you know historically how alcohol is viewed by our leadership. That's why there's lots of BCRs not to use alcohol. It's because of the association with you know, First Nations family destruction with use of alcohol. So there's lots of fear about that, and rightly so. But just also recognizing it wasn't until 1780 or so that there was documented use of alcohol by First Nations people. And that really was in response to the onslaught of colonization, destroying the lands, destroying access to proteins, and starting to harness people for the Europeans to come and take the lands. So that's quite traumatic for our ancestors. What we did just quickly, we integrated healthcare into the managed alcohol program. So it was necessary when we got to one of the hotels. We had to send people to emerge. People had what suspected brain bleeds, fractures, severe infections that were unattended to for these evacuees, and the kind of the very, very difficult times they had sitting in a hotel. A lot of times they're racist, the hotels. People weren't getting support. So that's kind of what we came upon. And we established in a fairly quick way a managed alcohol program. And at the height of delivery of the Muskegee, there were about 100 to over 100 people would come twice a day to receive the medicine. And so that's that mechanics of doing that, that operationalization. I'm not going to talk about that. I really want to talk about the impact that this has had. And again, as all of you have acknowledged, I want to acknowledge the Turtle Team, MKO, the province, FNISM, and other organizations that were incredible. The work that was happening that we saw at the congregate sites. Next. So it's more than the provision of Muskegee or alcohol. It's really relationship building, primary care access, traditional healing practices. Next. So we had about 230 total number of participants representing 9 nation communities who access services. We influenced legislative changes to the Liquor, Gaming, and Cannabis Control Act of Manitoba, specifically by expanding Section 72B of the Act to accommodate the delivery of MAP in Manitoba. So now we have our colleges of medicine, colleges of nursing. The systems realize that we need to gain access to alcohol as medicine. And so we worked through that actually over the last 2-3 years. Next. That's going to go. And I'm going to let Ken talk about this. I think this is the most important slide for our audience to see the evidence. So Ken, go for it.
So as we started winding down the managed alcohol program the last week of September, we started looking at doing evaluations with the participants themselves. And as Barry said, the most significant piece of a managed alcohol program is not necessarily the delivering of the muskegee or the medicine, as much as it is found within the therapeutic relationships that were developed with the participants of the MAP. Those relationships were based on the staff, and I do want to put a shout out to the Red Response team who we partnered with. They were instrumental in supporting the development of these therapeutic relationships that were really framed within a training that certainly included the context of the community members, where they came from, the historical trauma that they have endured, along with the proximal trauma, and truly giving them an understanding of how their lives were initially disrupted by colonialism, but continue to be so to this day by the impacts of colonial structures and practices within the provincial and federal helping bureaucracies. So in regard to the participants themselves, within a group focus setting, we were able to canvass them and get responses that clearly demonstrated the benefits of the managed alcohol program. A number of the folks reported a decrease in their alcohol intake. So getting that daily dose really kind of calmed and settled these people. They were not engaged in those survival drinking strategies. When Dr. LaValle and I first did our first site visit to kind of assess needs for the MAP, we ran into several community members who were ingesting hand sanitizer, were using mouthwash and other harmful non-beverage forms of alcohol. So clearly, we also saw a reduction in the use of non-beverage alcohol, which was very positive. Interestingly, when looking at the connections with family and friends, we saw improved relationships. The participants reported that they were no longer engaged in those strategic drinking, the drinking, the survival drinking strategies. They were able to reconnect with family, and we facilitated that in a lot of ways. The MAP had an incredible effect on the way that the participants saw themselves. When we first connected with them, they were very traumatized and highly confused in regards to the placements and the activities and just the whole environment of the evacuation. A lot of confusion and a lot of negative self views. We saw that change drastically again when people stabilized and really had pulled away from the survival drinking strategies and the conflicts, those behaviors that accompany binge drinking. They started changing the way they viewed themselves, and that was quite remarkable. 100% of the participants within the MAP program felt respected, seen, and heard by the MAP staff. Again, we do use a trauma-informed approach. We use a lot of humor. Working with First Nations people, what I've learned as a settler is that humor is a soothing and a healing relational component. And it really, we had a lot of laughs in the MAP. We had a lot of tears, but we had certainly more than anything, participants feeling respected, seen, and heard by the staff. So that would be it.
Yeah, that's good. And let's go to the next slide. This, I'm not going to go over this. There's a timeline. All of you have your timelines next. Where are we here? The future of MAP. The future of MAP. We're going to be looking at our mobile outreach program, which is located in Thompson. And that money came from the province for us to actually work with primarily First Nations people who are displaced from their homes and they live in Thompson. We're going to be looking at local needs for First Nations communities and working with chief and council to kind of work through that. Sometimes alcohol can be used as medicine. It's a hard concept for a lot of people to see. Looking at ways, working with Aboriginal health and wellness, and still working to support the provincial government with innovative ways to address the unhoused in Manitoba. Next. And I want to tell you also that the stereotypes about First Nations people who use substances and alcohol are quite dominant. I'm going to tell you that when we first opened up, there was a line of about 40 people. You know, you could tell that they were consuming alcohol. Not once were we threatened. Our staff were ever threatened. Not once. There was no violence. And so that counters the stereotype. Indeed, things were going on, and all of you know that. But our participants, once they actually came onto the program and they were talked to and they were respected, it was a phenomenal experience. And I want to thank you for listening to us. But that'll be it. Thank you.
Thank you so much, Barry and Michael. I think it's a really good reminder that as much as we would all like it not to be the case, there's still racism that exists in our society and in our systems, and that impacts people on a regular basis. And you had very firsthand experience of how that impacted the participants in your program, and we're very grateful for you sharing that. And it's a challenge, and it's something that we all have to learn from. I want to thank all of our presenters today who are willing to share the hard lessons learned and to also cast vision for the future, which included challenges but also hope. That's not an easy thing to do in the face of such such challenges, such things that we face with the wildfires and evacuation. And we know that the hard work is being done by people like you, and we're very grateful for it. We're going to have some time for questions now, and so I can see the question box on the side, and if people who are participating want to put questions in there, we're going to pass them on to our organizers. So the first question we have is for Ashley from MKO. It says, pardon my ignorance, but is there an emergency evacuation booklet that was created or can be created to include the various services and organizations that our relatives can contact as they're being evacuated? I'm thinking about distributing before evacuation, not after they have arrived, to reduce the frustration of waiting and living in the unknown.
That's a great question, and thank you for that. So actually, throughout this summer, we actually started to develop a resource directory. So, but again, that was just during the whole response. So with everything else going on, and we were getting nonstop questions about where to go. So we do have that as a way, we are taking that away as a lesson to be learned in action, is having a directory available beforehand, outlining clear roles and responsibilities and pathways for when they get back. So heads up to all the partners, I will be reaching out to include your information in that as well. But that's a great question, and it was a need and a gap that we saw, and we'll do our best to action it with all partners.
Mm-hmm. And I think that really goes back to one of your main points about being really proactive, about anticipating some of those needs and making sure that, you know, we're doing things before it becomes emergent. You know, it's good to have the life jacket before you fall in the lake, right?
Definitely.
This one is not a question, but a comment. It says, "Thank you for everything you have done to support our kinship. I have so much respect for you and the organizations that support our people, Miigwech." I think that's for all of you. And then we have another question saying, "Are there any plans to communicate and or collaborate with RCMP for mobile outreach and or maps?" I think that question is probably for Kim.
Do it. Yep. Okay. Hi. Thank you for that question. Yeah, that's, trying to be positive about incarceral states imposed on First Nations people historically and current. I'm probably not a good person to respond to that. However, we did try to develop a relationship with the Winnipeg Police Department and get data on where the activity or the noise was. But what we found with Winnipeg Police, and the person we worked with was great, but still the racism and the stereotyping of First Nations people was dominant. When we started the map, we were told that violence had increased, that people going to Main Street Project had increased, that we've overextended the system, and that was completely incorrect. In fact, we sent people were sitting outside the hotel up to 11, 12 at nighttime and just seeing, because we knew who was involved with our MAP program. Our MAP participants did not participate in violence or anything of that nature. And we also heard people accusing us of actually bringing kids into Child and Family Services by giving alcohol to their mothers. That's a ridiculous accusation and a ridiculous statement. When all of us here know, all the First Nations here know, that our access to Child and Family Services started 50, 60 years ago. This is not a thing that a MAP using alcohol as medicine does. So we had to counter those things. When we were in Shamattawa, the young fellas who were COVID positive, they had no memory, right? Go forward, backward memory. They had nothing because they were using a lot of alcohol to cope. And we delivered, within 2 weeks, we delivered the first map in a First Nations community. And the brilliance that arose from that, we've not published, but 50% of the people who went on a map within a year to 18 months were back at work. Like, you got to think about that. Our relatives on Main Street. Imagine if we could do a map and 50% of them got their families, 50% of them, went back to work. Like, these are significant things. And it was all based on a therapeutic relationship. How you doing? Come back at nighttime. How you doing? Is everything okay? Did you get food for the kids? Or all those kinds of things. It's not about the alcohol. It's only a temporary bridge to take care of withdrawal symptoms, et cetera, et cetera, et cetera. In fact, we have a video from our work in Shamattawa where a young man is talking, and he's saying, "I decided to go on MAP because I didn't want to die because their mother died of alcohol for his babies." And he said, "I'm sober." And so for the people in the AA, they think that's crazy because we're still giving him twice a day dosing of alcohol. So he could never be sober. But he himself saw his mind as sober. There was clarity there, his responsibilities. So, and in that particular environment, they brought forward 7 cases to us that were the quote unquote problematic residents of Shamattawa. We put them on a managed alcohol program, and 2 weeks later we met with Chief and Council and RCMP. And the Chief and Council was getting calls from the community members saying, "Why is it so quiet? What's going on in our community? Now, just remember, this is 7 people from over 1,000, okay? And the RCMP said, what's going on? We're not getting any calls. The nursing station said, we're not getting people banging on the doors at 3 and 5 in the morning. And you got to think that we've never taken care of the needs of people who are that traumatized. And we give them crap when they go to the nursing station, wake up the nurses 3 and 5. It means that we, as providers and systems, have never met their needs. So that was a really, we drew a lot from that. And so that's why we believe in the managed alcohol program as a Muskegee for healing.
Thank you for that. We have a follow-up question that I think is related, which is, where can I find more information on MAP and how a person can access it? And then the person asking the question says this is the first they're hearing of this program.
So managed alcohol programs in Manitoba are relatively new phenomena. Clearly, here at KIM, we have led the proliferation of MAPs across the province. There is not one specific spot that you can access to get the ABCs of a MAP program. Certainly, we at KIM have a lot of experience. We're in the process of finishing off a program evaluation of our experiences in the summer that we will likely be sharing with the province. But I know Main Street Project is running a small little managed alcohol program in the city here. As I said, we are supporting a managed alcohol program in Thompson that has provided services for over 3 years. We're probably have supported at least 45 to 50 people over that period of time. Many of those people within the MAP program in Thompson have moved on into treatment, have moved on, as Dr. LaValle pointed on, into employment, into stable housing, and are doing really well. But if there are any questions around a managed alcohol program, they can contact us for sure.
Please do.
Thank you so much. Yeah, I'm hearing that as this program continues and as it expands, there's the knowledge that's gained from it is likely to reduce the ignorance around it, which will probably make the general public and a lot of service providers more understanding and accepting and supportive of the benefits that it can bring. So thank you for that, and for all of our presenters who navigated the really challenging waters of the wildfire season with us and have been patient with those of us in the system who were trying to help. We appreciate you. We want to learn from these lessons you're giving us and set things up for the future in a more proactive way. And we're honestly just very grateful for the time you spent with us today. Thank you for what you've shared with us. And that's our time. So we're going to thank everybody for coming, and we'll see you at the next KE Day session. Goodbye.